and welcome to Knee Talk. Today we're going to discuss options before total knee replacement. Total knee replacement may well be the right option for your knees. However, before you commit to surgery, you should be aware of what options are available and consider each one in turn to see if pain relief and function can be achieved without surgery. Firstly, braces or supports. Knee braces work by simply reducing movement within the joint. By stiffening that joint, it reduces painful movement in deformed joints and gives you a feeling of support and stability. Secondly, a knee support can increase the activity of the skin nerves, which work in combination with your muscles, again giving you a feeling of support and stability within the joint. Lastly, knee supports make the knee feel warm, which is never a bad thing. Secondly, supplements. In early joint disease, supplements can be effective. We don't have any large patient data that supports them scientifically, but we have some indirect evidence from laboratory work and certainly lots of anecdotal evidence from patients who find supplements help them. There are several types of supplements you may want to consider: omega-3 or cod liver oil, glucosamine, chondroitin sulfate or turmeric. All of these work to some degree, but my advice is to buy the cheap generic brands rather than expensive brands. They're essentially the same and certainly work the same. Think of supplements as part of your daily diet. Take them regularly over a long time. If you miss a few, it really doesn't matter. If they're going to work, they're going to work for all the joints in the body, so they might not be as effective as you want for the one joint that's painful, but they'll help the rest of the body. Painkillers. Simple painkillers can be effective. I always advise starting with paracetamol. Taken regularly, it can be very effective. Obviously there's an upper limit and you mustn't take more than 8 a day in the UK, but if you take them regularly, they will help. Anti-inflammatories such as Brufen, Nurofen are very effective in reducing inflammation in joints. But there are some rules to apply. Always take them on a full stomach. Avoid if you genuinely have asthma, and take them in short, sharp courses of 3 to 5 days rather than long term. There are some long term side effects if you take too much, so you need to be a little bit careful. If you use them properly, they will work. Lastly, opioids, morphines, the high-end painkillers. These can be used for short-term relief whilst awaiting surgery. But if you're at the stage where you need morphine, then surgery is an option you should seriously consider. Of course, at all times, speak to your own clinician about taking painkillers and taking them in combination. Injections. Injections you can divide into 3 broad groups: anti-inflammatory, lubricant, and regenerative. And I'll talk about each one in turn. Anti-inflammatory injections, essentially steroid. Steroid, we have lots of evidence about how and why it will work in an inflamed joint. It's a very safe injection we've been using for many years now. Normally we'd use it in combination with an anaesthetic, so one needle will give you pain relief and anti-inflammatory. If they work, they can be repeated, though not too often. Too many steroid injections leads to diminished response and effectiveness. And again, always question a clinician if he's repeating the same injection again and again if we're not getting the response. Next, lubricants. High hyaluronic acid, which is a normal enzyme within the joint, can be used to lubricate a dry, non-inflamed joint. The science behind this is a little shorter than with steroids, but there's good anecdotal evidence that patients find them effective. It can be done as a single shot and it can be repeated. Lastly, regenerative injections. Essentially putting growth factors back into the human body. And we do those by taking a blood sample, spinning it down, taking out the growth factors and injecting them back into the affected joint. The science behind this is not as good or as long as with other types of injections. However, in the right hands, for the right indication, we can see an improvement in symptoms in arthritic joints. Weight loss. Now this is something nobody wants to talk about, but probably we all should. As a patient, this is the single biggest thing you can do to help yourself reduce pain in arthritic joints. The knee in particular is very sensitive to weight loss. When you think of it, about weight per square inch of joint, the more weight you're carrying, the more goes through the joint and the more pain you get. So weight loss really should be a major part of pre-operative management. And in many cases you can delay or avoid the need for surgery if you reduce weight considerably. Not only that, if you lose weight, the operation itself becomes safer. Every single complication is reduced if you lose weight. In particular, infection can be reduced sixfold if you reduce significantly your weight before surgery. All surgeons in the UK would ask patients to lose weight if their BMI is over 40. If you're over 50, you probably will be denied surgery in the UK because the risks outweigh the benefits. But that's something on an individual basis you can discuss with your surgeon. Before knee replacement, there are other operations we can perform. The simplest being arthroscopy, a keyhole operation on the knee. And through keyhole surgery, we can remove excess bone that prevents you straightening the leg. We can remove loose bits of bone and cartilage. We can trim up unstable cartilage that's locking the knee and stopping you from using it. And sometimes we can help the joint surface repair by cleaning out unstable material and stimulating growth from the bone marrow, often called microfracture. Arthroscopy sometimes gets a bad name because it's an easy operation to do, and surgeons will try and help you and often do too many arthroscopies. If you do too many of the same operation, you'll get diminishing returns. So again, if your surgeon's promoting one more arthroscopy, you have to ask them, do I need a different operation? Has arthroscopy had its day? One more operation we can perform before knee replacement is called osteotomy, essentially breaking and resetting the knee so it's straight. We can do that in young adults whose legs have become bowed or knock-kneed because of degeneration, arthritis in the knee, so that the mechanical alignment of the joint is straight again. This can be very effective by taking the pressure and the pain off one small part of the joint and redistributing it throughout the knee joint. Not everybody can have an osteotomy. Sometimes the disease process is too advanced or too widespread for osteotomy to be effective. Sometimes the disease itself is beyond where an osteotomy can reasonably help. Osteotomy is not without complication. If we break a bone, it has to heal. Healing may be delayed or not happen at all. You can get infections, you can get blood clots, and sometimes we correct the alignment and we can both overcorrect and undercorrect. It's a technically highly demanding operation. Lastly, to hold the correction, we use fairly sizable plates that will take your weight load. And the bigger the plate, the more soft tissue irritation we get from those plates. And not infrequently, the plates needs to be removed before you get the best outcome from your osteotomy. So if we can get the knee comfortable by using injections, tablets, braces, then we can build on that comfort with physiotherapy to maintain movement in the joint and strengthen the muscle. The stronger the muscles are, the more support the knee can get. So I've given you 8 options to consider before total knee replacement. Braces or supports, supplements, painkillers, injections, physiotherapy and weight loss, and then relatively minor operations, arthroscopy, and a more significant operation, osteotomy, all of which are designed to give you comfort, function, and to keep your knee working before knee replacement becomes the correct option for you, hopefully many years ahead.